Bradycardia. Okay, that's also right. Thank you. Thank you, neurolethargy. That's right. Then they have done an examination. So on the initial examination at the ER, the patient was lethargic and speaking inappropriate words. And on painful stimuli, he was opening his eyes and localizing the pain. The patient was moving all the limbs and the neck was supple. Supple here meaning that the neck is flexible, which is not, there's no neck stiffness, which excluding meningeal irritation that could occur with some cases, as an example, subarachnoid hemorrhage. The pupil were 2 millimeter and reactive to light, which means that it is in the normal diameter, which is from 2 to 4 millimeter, abnormal light reflex. The pulse is 52 beat per minute and regular. The blood pressure was 170 over 100 millimeter mercury. So the patient is bradycardic and hypertensive, and we will explain how does this occur in the next few slides. So without looking to the slides, according to the patient history, which is a minor trauma, and he have signs and symptoms of increased intracranial pressure, can you give me a possible differential diagnosis of his condition? Okay. Okay, that's right. Thank you. Okay. شكرا جميعا. تمام شكرا جدا. Okay, so that's right for all of you. So all of these differential diagnoses, we can differentiate between them simply by ordering a CT scan. So in case of the subdural hematoma, we will see a crescent shaped collection, while in the epidural hematoma, we will see a biconvex lens plus a fracture of the skull. And in the intracerebral hemorrhage, we will ask, of course, about the history of alcohol use and illicit drug use as amphetamine, cocaine. And we will see a characteristic star sign in case of subarachnoid hemorrhage. While in case of diffuse axonal injury, the patient will have a history of high-speed motor vehicle accident, and also he will have a characteristic CT scan, which is a multiple hemorrhagic foci, specifically at the gray-white matter junction, and also he will have brain edema on CT. And we can confirm it by special MRI. Then they have ordered an urgent CT scan. During the transportation, the patient suddenly deteriorates. The second question is the Glasgow scale of the patient initially and on reassessment. So initially, the patient was opening his eye in response to pain, so he will get 2 points. He was localizing the painful stimuli, so he will get 5 points, and he was saying inappropriate words, so he will get 3 points. So 3, 5, and 2, the summation is 10. So this means that the patient have a moderate brain injury. While after the reassessment, the patient wasn't opening his eye at all, so he will get 1 point, and he have an abnormal flexion. So he will get a 3 points. And abnormal flexion, also called flexion rigidity or decorticate position, a posture. And he was saying an incomprehensible sound, so he will get 2 points. So 2, 3, and 1, so it is 6, less than 8, so the patient is having a severe brain injury, and this means that the patient is unconscious. So, the third question is explain the changes on the heart rate and the blood pressure. Uh, the patient was bradycardic, as we have mentioned, and having hypertension. So this is simply explained by something called a Cushing reflex. And this Cushing reflex is occurred due to an increase in the intracranial pressure. So when there is an increase in the intracranial pressure high more than the mean arterial blood pressure, the intracranial hypertension will compress on the blood vessels, leading to cerebral ischemia, or in other words, it will lead to decrease the cerebral perfusion pressure. So that will lead to activation of the sympathetic nervous system, which will lead to hypertension via vasoconstriction, via the action on the alpha 1 receptor. And the hypertension will stimulate the parareceptor that present in the carotid and the aortic arch, which will lead to parasympathetic activation, and so the patient will develop a bradycardia. And the continuous increase in the intracranial pressure and hypertension also will lead to compression on the brainstem that contain the respiratory center, and so the patient will develop an irregular breathing. So as a conclusion, the intracranial pressure will lead to something called a Cushing triad, which is composed of bradycardia, systolic hypertension, and irregular breathing. Irregular breathing, also called a Cheyne-Stokes respiration. So an important thing to know here is that the increased intracranial pressure is a medical emergency that can lead to cerebral herniation and eventually death. So that's why we should as soon as possible or immediately. The fourth question we have is what is the posture seen in the picture, and explain the localization? So this is called a decortical posture or a flexion rigidity, and it is occurred due to a lesion just above the red nucleus. It could be anywhere above the red nucleus, including in the cerebral hemispheres, in the internal capsule, the thalamus, upper midbrain, and others. So what is the action of the red nucleus? The red nucleus is responsible for predominantly flexion of the upper limb, and it is regulated by impulses from the cerebral cortex. So when there is a lesion above the red nucleus, the red nucleus will lose its inhibitory impulses from the cerebral cortex, so it will start to release a strong impulses to the flexor muscles of the upper limb, leading to the flexion of the wrist and elbow and reduction of the shoulder. And the vestibular nucleus will send impulses through the vestibulospinal tract to do extension of the lower limb. Then we have this picture. So what do you think the cranial nerve is affected in this patient, according to the left eye presentation? That's right. شكرا جميعا. So the patient is having an oculomotor nerve palsy, which is actually due to the hematoma that has led to an uncal herniation. The uncus is located in the inframedial aspect of the temporal lobe. So when it's herniate, transtentorial, which is the membrane that present between the cerebrum and cerebrum, it will lead to compression of the third cranial nerve that supply different muscles, including all of the extraocular muscles, except the superior oblique, which is supplied by the fourth, and the lateral rectus, which is supplied by the sixth cranial. And so the patient will have an exotropia as shown in this picture, which is an outward deviation of the eye. And also the patient could have a hypotropia, which is a downward deviation. Also, the loss of the innervation to the constrictor pupillae muscle will lead to an ipsilateral mydriasis. As you can see in here, the pupil is dilated and fixed. Fixed means that it is unresponsive to the light. Also, the patient could have a loss of the innervation to the levator palpebral superioris muscle and presented with ptosis or dropping of the upper eyelid. The sixth question is a possible localization of the coma. Uh, which is simply mean that by a specific neurological examination, we can identify the possible cause of the coma, whether it's a structural or a non-structural cause. Then we can also localize the structural cause. So the neurological examination composed of four things, which are the respiratory pattern, the papillary response, and the the ocular movement and the motor response. So since our patient have a decortical posture and his eye was dilated initially due to the third cranial compression, and later on, the patient will have a midbrain compression, which will lead to a mid-position pupil. And so the patient will have an abduction deficit due to third cranial nerve damage and the Cheyne-Stokes respiration that we have talked about in the Cushing triad. So this is the diagram of the Cheyne-Stokes respiration, which is simply deep periods of deep inspiration with episodic apnea. So deep inspiration followed by periods of apnea and so on. So the cause of coma in this patient is actually a structural cause, which is specifically asymmetrical because it is a unilateral and it is located supratentorial, which means that above the tentorium cerebelli, which is the membrane between or separating the cerebellum from the cerebrum, and also the patient have a ankle herniation. So the seventh question is the finding of the CT scan. So as you can see in this CT scan, we should explain نشرحها يعني in a radiologist's way. So we will begin with the type of the imaging. So this is a non-contrast axial CT scan brain window that shows a large crescent-shaped hyperdense collection along the occipital-parietal region. And there is also a midline shift to the contralateral side, as you can see in here. And there's effacement of the sulci or the sulci, and enlargement of the visible part of the lateral ventricle, and also a soft tissue swelling, as we can see in here. So the diagnosis from the CT is a acute subdural hematoma. We say acute because it is a hyperdense collection, while in case of the collection was isodense, so it will be more with the subacute subdural hematoma, and in case of the chronic subdural hematoma, we will have hypodense collection. So the last thing is the management. So the management of this patient begins with the primary survey. We will do ABC. And as we know that the A refers to the airway, so we will secure the airway by intratracheal intubation if needed, and so on, as we have taken VGS. Then we will do a neurological examination plus imaging to identify whether the patient needs neurosurgical intervention or simply conservative management. So the patient is asymptomatic, stable, with reactive symmetrical pupils, and Glasgow scale less than 9, and the subdural hematoma less than 10 millimeter, and midline shift is less than 5 millimeter, and the intracranial pressure was less than 20 millimeter mercury. So we will treat him conservatively and follow up the patient by CT scan in a period of 2 to 3 weeks after this. So management including reversal anticoagulant. As an example, the patient using a heparin, we will give the antidote, which is protamine sulfate, and if the patient using warfarin, we will give 4F BCC plus vitamin K, and so on. And also we will manage a raised intracranial pressure simply by raising the head of the bed 13 degrees and giving analgesic and sedation if the patient is agitated or in pain, because those will increase the intracranial pressure. And also we can hyperventilate the patient, which can also decrease the intracranial pressure. Second options of reducing the intracranial pressure is by introducing a hypertonic saline or giving an osmotic diuretic as a mannitol. And it is highly recommended to give patient an anti-epileptic as phenytoin or levetiracetam. Levetiracetam is preferred more than phenytoin because it has a less adverse effect, and we will give it for 7 days after the presentation to avoid post-traumatic seizure. While the indication of the surgical management is the opposite for the indication of the conservative management. But in addition, we have failure of the conservative management, signs of cerebral herniation, and drop 2 or more points of the Glasgow Coma Scale from the initial assessment. Options that we have in the surgical management is the craniotomy with evacuation, which is the preferred one, and other, which is a decompressive craniotomy, which is indicated in case of cerebral edema or herniation. And also, the paramedic can do a parallel craniotomy if, as a temporary intervention if the definitive management is delayed. So after the surgical management, we will monitor the Glasgow Coma Scale of the patient to see the improvement, and also we will monitor the intracranial pressure by ventriculostomy or another methods. So we will reverse anticoagulant because in BMJ they have mentioned that many patients with a severe head injury present with a state of DIC, which require a normalization of the coagulation. And that's it. Thank you. These are my references. Sorry.
Thank you so much, Dr. Alina. Well, detailed presentation يعني يعطيك العافية for all the information that you mentioned it. Just 2 notes about the presentation. You mentioned about the Glasgow Coma Scale and the decurticate about it. Usually we don't use the Glasgow Coma Scale for decurtication. It's about the position of the patient. It's not about for the pain stimulation and how the patient heat movement. So it doesn't relate to it. Okay, this is just one point. Plus about the Keppra or levetiracetam as anti-prophylactic for the seizure itself. Usually we don't give it for the patient unless there is a need. If the patient here start to have a seizure, at that time usually we start the antiepileptic for the medication for the patient. And again, thank you so much for the good presentation that you did put in good effort for it. Thank you so much.
Good evening. I'm Yara Tlan, and I will be discussing the second case of clinical reasoning of coma patients. So, my patient is a 62 years old gentleman brought to the ER with 2 hours history of sudden onset dizzy spell, vertigo, headache, dysarthria, and weakness of the right side. He is known to have long-standing diabetes, hypertension, ischemic heart disease for the last 2 years, smoking history of 1 pack for 10 years. While at the ER, he suddenly started to deteriorate. He had 2 episodes of vomiting, developed decreased level of consciousness, and started to desaturate. So all of the first line will indicate that it's an acute onset of a disease. It's not really specific for any cause, while his history of or the past medical history is making me think of a stroke, since he's diabetic hypertension and ischemic heart disease. So all of these are risk factor for ischemic stroke because of the atherosclerosis. Also, he has a smoking history. And the last lines, which is decreased level of consciousness and started to desaturate. The desaturation, since is making me think that it's a brainstem lesion and not a cerebellum region. So in examination, he was drowsy, not opening eyes to pain, had incomprehensible sounds and extension on painful stimuli as seen in the picture. All of these will be explained later. Pupils were 3 millimeter bilaterally, sluggishly reactive to light, so he's not reacting to the light. The dual eye movement or the oculocephalic reflexes are absent. It will be explained later. He had a bilateral extensor plantar responses or a positive Babinski reflex, not really specific for anything, just making me think that it's a CNS problem. So all of his vitals are normal. So the pulse was 68 beats per minute regular. Blood pressure is 115 over 70. While the oxygen saturation is 80% with face mask oxygen supplementation, which also makes me think of a brainstem lesion. So the differential diagnosis for this patient, any coma patient or any coma patient, the differential diagnosis can be summarized in this mnemonic, which is coma. The C is for CO2 necrosis, like in respiratory failure. For in respiratory failure, since he is desaturated, it can be or it can be O is for overdose for alcohol or salicylic acid or aspirin. But he's not showing any toxic overdose symptoms. Metabolic for hypoglycemia, DKA, hepatic coma, which is why I will ask later for the glucose level and for the liver function tests. Lastly, A for epilepsy, any head injury, we can take history, but since the patient is unconscious, we can ask the one coming with him. Stroke, either hemorrhagic or ischemic. Since he has a risk factor for stroke, this is most likely for now. Subdural or extradural hematoma, or it could be any type of infection like meningitis, encephalitis, or even epilepsy. So the Glasgow Coma Scale for this patient, in the history, it says that he's not opening eyes to pain. So the patient is eyes are not responded to any stimuli. The score is 1. He had incomprehensible sounds. So he has a verbal response, but it is incomprehensible, which is why he will get 2. Extension on painful stimuli. This is also so the motor response is still intact, just that it is extending and it is only on painful stimuli, which is why he will get 2. So all his scores, or the score of this patient is 5. It is less or than 8, which is indicate that it's a comatose patient or a coma patient. So the oculocephalic reflex or the dual eye movement. In summary, it is when we shake the patient or when we move the patient head from left to right, the eyes will still will be flexed straight like a doll. But normally, when we move the head to the left, the eyes will move to the right. And in contrast, when we move the head to the right, the eyes should be moving to the left. And then in between, when the patient head is straight, his eyes should be straight as well. The oculocephalic reflex is a brainstem reflex. So since the patient has a negative oculocephalic reflex, it indicates a brainstem injury or lesion. How will it manage? So it's a trauma patient. First, the ABCDE. He's a coma patient, so intubation is a must to maintain the patent airway. Then breathing, since his oxygen saturation is low, so mechanical ventilation. And we will check the circulation, so monitor the vascular system, and we will establish IV access in case he deteriorates. So after intubation and mechanical ventilation, planned CT scan of the brain was done, which is shown. Firstly, which is the CT scan without contrast. Um, we can see in the midbrain decreased attenuation, meaning or يعني I will think first that the blood supply was cut off for any reason. There's no signs of hemorrhage. It is important to establish if there's any sign of hemorrhage when we do CT of the brain for further management later. So comparing the CT of my patient to the normal CT, you can see that it's all the same color, while in this patient, it is darker. The brainstem is darker than the rest. A hemorrhage in CT is shown in a lighter color. The MRI, first, which is the FLAIR T2. The FLAIR T2 will show hypertense signals with the infected tissue. Unlike the CT here, it is lighter than the rest. And the DWI, there is a restricted diffusion comparing to the rest of the brain tissue. All of these, this one in particular, is very sensitive and specific for brainstem stroke or the basilar artery occlusion. Before we move to the management, it is very important to know that in case of basilar artery occlusion, it is very crucial to start treatment before 3 hours or before 6 hours for favorable outcomes. So after the CTs are done and we see that there is no hemorrhage, then we can give thrombolysis or which is alteplase. It must be, or it is preferably be giving before 3 hours of the onset of the symptoms, not from when the patient came to the hospital. And then antiplatelet, we will give aspirin 80 milligrams within the first 2 days. And mechanical thrombectomy, since the artery that is occluded is a large artery. That's all. Thank you.
Thank you so much, Dr. Yara. يعطيك العافية على the presentation. Well done. Any question anyone would like to ask Dr. Yara before I make any comment? غالبا إذا كان البيشنت he will receive الإلكترون الانزعاج اللي عندي، بس غالبا اذا كان البيشنت will receive اللي هو الثرومبولايسيس usually wouldn't give له انتي بليتد بالنسبه له هو. Just one comment about اللي هو السي تي برين. When you describe السي تي برين، السي تي برين احنا نقولها density، فاذا كانت white as you said or light in the color we see it we told it's hyperdensity. Okay, اذا كانت dark we call it hypodensity and it's a sign of the blood, while as in the DWI one of the gold standard for the stroke regarded هو DW diffused white image. فغالبا في الام ار اي احنا غالبا نقول عنها انها intensity for a signal، فهايبر intensity وهايبو intensity بالنسبه للسيجنال. These just a few things. Other than this بصراحه يعطيك العافيه.
Okay, Assalamu alaikum. Can I start, Doctor?
You should proceed, Dr. غايدة يعطيك العافية.
Okay, Assalamu alaikum. Hello, everyone. My name is Ghaida Al-Mazrouh, and now I will discuss case 3. Okay, so we have a 70 years old lady known to have multiple medical problems. She is diabetic, hypertensive, got ischemic heart disease, and chronic kidney disease. She was unwell for the last 2 days, drowsy with abdominal pain and recurrent vomiting. Presented now to the ER with unconsciousness, and she has no history of fever. Drug history include gliclazide, insulin, losartan, aspirin, and atorvastatin. Okay, on clinical examination, she is comatose, opening her eyes on noxious stimuli. She has inappropriate words, not obeying command, and withdrawal to pain. She also got generalized sweating and tremors. Her pulse was, her fatal signs included pulse was 110 beat per minute, blood pressure was 110/85, temperature was 37. During examination, she developed a brief episode of jerks of her limbs, and she has no neck stiffness or no focal neurological deficit. Okay, so here are the questions. How much is her coma scale? What is the possible localization? And what is the possible causes for her coma? What is the emergency test that should be done for her? And how will you manage this patient? Okay, so her glaucoma scale, as I said before, she was opening her eyes only to the noxious stimuli, so we'll give her 2. Yes, we'll give her 2. And in the motor, she withdraw her hand from the pain. She will have 4. And in the verbal response, she was saying inappropriate words, so she would take 3. So her glaucoma scale is 9. What is the possible localization? Since the patient had no symmetrical presentation and no focal neurological deficit, most likely the patient is having a diffuse brain dysfunction, symmetrical involvement. And what is the possible causes for her coma? Okay, معلش محتاس السلايد. بس focus على ال general causes of coma, then we will talk about the information for the patient, then I will ask you to give me some differential. So general causes of coma include metabolic causes, trauma, vascular causes, infection, and others. So in the metabolic causes, maybe due to drug overdose, maybe related to diabetes mellitus, maybe hypoglycemia or hypoglycemia, also maybe due to hyponatremia, uremia, or maybe due to hepatic failure from hyperammonia. Trauma may be due to cerebellar contusion, extradural or subdural hematoma, also may be due to vascular cause, such as in case of subarachnoid or intracerebellar hemorrhages, infection, which included meningitis and encephalitis, and others, epilepsy or brain tumor. So our patient was diabetic, hypertensive, and she got ischemic heart disease and chronic kidney disease. She was in a sulfonylurea drug, which is gliclazide, and she was also taking insulin. She has history of abdominal pain and recurrent vomiting and has developed drowsiness, no history of fever, and no neck stiffness, no focal neurological deficit. She got generalized sweating and tremors. So based on the patient presentation, can you give me a differential from these general causes? It could be the patient maybe presented with possible cause for coma in this patient. Mm. Okay. Okay. All of these are right because she is diabetic. Maybe she have hypoglycemia or hyperglycemia. But the patient is presented with abdominal pain. She also had recurrent vomiting and developed drowsiness. And she was on a sulfonylurea drug, which has a side effect of causing hypoglycemia. And she was also on insulin. Also, she developed sweating and tremors. all of these suggest that the patient is having hypoglycemia. Also, during clinical examination, if you remember, the patient had a jerky movement. Maybe this is due to this is associated with hypoglycemia. Maybe the patient will have a transient impairment in the pyramiddle tract, so they will also develop jerky movement. So most likely the patient is having hypoglycemic coma. Other causes, because she is diabetic, maybe hyperglycemia, stroke, and also because she had a chronic kidney disease, maybe due to severe uremia. Also diffuse brain dysfunction, which is the localization in this patient, usually presented with metabolic disturbance, which the patient is having. What is the emergency test should be done for her? She's diabetic, so we will order blood glucose. It was ordered for the patient, and she had a low blood glucose. It was 1.5, and the normal was 4 to 5.4. How will you manage this patient? First, we will do our immediate management. We'll do the ABC, we'll maintain the airway, we'll check the breathing, and we'll maintain the circulation. Then we'll give IV dextrose. If it's not available, we will use intramuscular glucagon. Then after that, the patient, of course, we will need to change her current management to the optimal and educate the patient to stick to her medication. These are my references. Thank you. Do you have any questions? Thank you.
Thank you so much دكتورة غادة، يعطيك العافية، نشكرك من الأستاذ. دكتورة نورا, if you are ready, you can start.
Okay. يا بنات وضحت عندكم الشاشة؟
لا.
Okay, because there is some animation I need.
Nora, can you try again, because it was loading and it stopped? Or maybe she tried to reconnect.
I'm Nur Atek, and today I will be presenting the last, which is the case 4 of the clinical reasoning for today. Okay, let's get started then. So our patient is a 43-year-old man was brought to the ER unconscious, and no one was with him to give any clues. Okay, so for the finding, the vital sign was within normal range. For a Glasgow Coma scale was 5. The patients have jaundice and also gynecomastias and palmar erythema, as you see here, and also they have a spider nevi. Okay, so for our patient, Glasgow Coma scale was here. It's 5. Then it's our patient was comatose. Okay. And here, as my colleagues explain how to calculate the Glasgow Coma scale, but in our cases, it's already calculated. So, for the finding, the liver span was 4 centimeters. As we all know that the normal liver span is 6 to 12 centimeters in the right midclavicular line and 4 to 8 centimeters in mediastinal line. The spleen of our patients was palpable. As we all know that normally the spleen will not be palpable except in certain situations like in slender young adult when the spleen can be felt below the left costal margin. This is maybe due to some diseases like it could be due to congestive causes like the like in some disease that lead to disorder in the splenic blood flow, so the blood will back up to the spleen, like in splenic venous thrombosis or obstruction or portal vein obstruction, or also in hepatic cirrhosis that may lead to portal hypertensions. Also there is some infectious cause for palpable spleen like in mononucleosis. Okay, so for finding, as you see here, what do you think the finding is? Like, guess. I cannot. It's not like video. So, what do you think the finding here? Yes, yes, right. Yeah, flapping tremor, asterixis. This is an early sign and it's characteristic for liver failure, but it's not diagnostic as it may occur in other diseases, such as in case of cardiac encephalopathies. For cardiac encephalopathy, the patients will develop confusion, lethargies, and cognitive and behavioral abnormalities uh, during or after cardiac decompensations. Uh, congestive heart failure is um, congestive heart failure and also the systematic elevation in the venous pressure and the decrease in the cardiac output can lead to these changes, okay, within the cranial cavities that cause cardiac encephalopathies. It could be respiratories or renal failure, as Yara mentions. It could be hypoglycemia, hypocalcemia, and hypokalemia. It could be hypomagnesemia, brain lesions, or drug intoxications like barbiturate and benzodiazepine. Okay, so continue with findings. The respiration was fast and deep. For the pupil was normal. That means it's equal, round, and reactive to the lights. There was no localizing sign. We know that localizing sign is the sign that's absorbed during the neurological examinations that might be give us a clue to a specific disease or lesions in specific area in the brain or the nervous system. There was no localizing sign, and there was no sign of meningeal irritation. As we know, the sign of meningeal irritation is carrying signs. The carrying sign is when the knee is flexed and the hip is flexed, there will be painful extension of the knee. Okay, and Brudzinski sign is when there with a passive flexion of the neck leads to passive flexion of the neck. They will lead to flexion of the hips and knee also. Okay, so moving on, what do you think the differential diagnosis in our cases? Yeah, Yeah, it could be cirrhosis, liver cirrhosis, and also it could be hepatic encephalopathy. It could be intracranial bleeding, subdural or extradural hematomas, drug or alcohol intoxications, hypoglycemia, and Budd-Chiari syndrome. So for investigation, the CBC was pancytopenia. For total bilirubin was 14 increase. Direct bilirubin was 7. We know that the direct or conjugated bilirubin is elevated usually due to alcohol or infectious hepatitis or drug reactions, and also during autoimmune disorder. But usually the post-hepatic disorder can also cause conjugated hyperbilirubinemia. For alanine aminotransferase, this is usually commonly elevated, as in our patient 100. The normal in male is 22 to 33. Here is elevated. Usually it's elevated as a response to liver diseases or liver damage. Okay, and albumin globulin ratios was decreased. The ratio decrease in liver diseases or cirrhosis, also in kidney diseases, and also it could be decreased in autoimmune diseases. For the thrombin time was increased, like we know that uh, it's increased. It will take a longer time for blood to clot. Why? Because the liver is not making a right amount of blood clottings. The clotting or process will take a longer time. Okay, this is suggestive of serious liver damage or cirrhosis. For ammonia was rise. Like here, the ammonia is increased in patients with hepatic encephalopathy, but the increase, but it could be increased in absence of the clinical encephalopathy. Okay, so we it's not it's have a little diagnostic value, but when it's normal we can exclude the hepatic encephalopathy, but we cannot because it might be increased and the patient have not a clinical significant clinical presentation of hepatic encephalopathy. Do you understand what I mean? I hope it will be clear for you. For the blood urea and serum creatinine, we all know it's increased in case of the kidney diseases. Here, also both increase. Okay, so what do you think the likely diagnosis of this case? It's clear that the patients have liver cirrhosis that's complicated by hepatic encephalopathies. So, what are the precipitating factor for hepatic encephalopathy? It could be some drugs, especially the sedative and antidepressant. It could be due to dehydrations, like including diuretic and paracentesis. It could be uh, uh, port to systematic shunting, tips, or portal vein thrombosis. It could be due to infectious causes, hypokalemia. It could be due to constipations, and also it could be due to increase in protein load in case of GI bleedings. Okay. Now, how would you manage this case? like let's see the grading of the hepatic encephalopathy as regarding to the West Heaven gradings. You see 0, there was no changes, no ataxias. 1, impaired concentration and attenuation span, sleep disturbance, slurred speech, epiphoria or depressions. For 2, it could be lethargy, drowsiness, apathy, and aggressions, and also disorientation, inappropriate behavior, slurred speech. 3, confusion. What do you think our patients have? Which grade? Before I continue, it's crystal clear. Which grade our patients have? Yes, our patient have grade 3 because he have confusion, disorientation. Yes, yes, thank you, Reem. Bizarre behavior, drowsiness, or stupor, astraxia, usually absence. For grade 4, the patients will have comatose with no response to voice or command. Okay, for hepatic encephalopathy, when we confirm the diagnosis, we check the ABC. Then, if it's grade 3 to 4, then we admit it to the ICU. We do the general management. If there's infection, there we will give systematic antibiotics, diuretics, and dehydration for the volume expansion. Gastrointestinal bleeding, we should control it. We give laxative for constipations. We give thiamine in case of alcohol bench. Also, in case of we correct the electrolytes and malnutrition. For specific therapy, we give this is the main treatment are lactulose and rifaximin. Okay, and also we can do a branch change amino acid, or also we can give albumin or extracorporeal albumin dialysis. But the specific treatment is lactulose, 10 to 30 milliliter 3 days, 3 times daily. This is the first line treatment for hepatic encephalopathy. It will improve hepatic encephalopathy and decrease the absorption of the ammonia in the bowel. As you see here, lactulose will be metabolized by the normal gut bacteria to lactic acid and acetic acid. Then it will convert the uncharged ammonia to a charged ammonium. Okay, a charged ammonium, relatively low absorption. Okay, and we give also rifaximin. This is non-absorbable antibiotics that will kill the bacteria that produce the ammonia. In case of chronic or refractory encephalopathy, we do the last option, which is liver transplantation. Okay, that's it. I hope it was clear for you. Thank you for listening, and feel free to ask any question. Okay, that's it, and this is my reference.
Thank you so much, Dr. Noura. يعطيك العافية for the detailed presentation. Well done for all of you. So we finished today our lecture. Thank you all for your presentation and for presenting, and also for your cooperation. Wish you all the best, inshallah, in your successful life. يعطيكم العافية جميعا.